Good afternoon. I'm delighted to welcome you to today's lecture, sponsored by the Bucksbaum Institute, which was created in 2011 with a gift from Matthew and Carolyn Bucksbaum Foundation. The goals of the Bucksbaum Institute are to improve patient care, to strengthen the doctor-patient relationship, and to enhance communication and decision-making between patients and physicians. Today, I'm delighted to introduce an old colleague and friend, Dr. James Tulsky. Dr. Tulsky is the chairman of the Department of Psychosocial Oncology and Palliative Care at the Dana-Farber Cancer Institute. Dr. Tulsky is also chief of the Division of Palliative Care at the Brigham and Women's Hospital, co-director of the Harvard Medical School Center for Palliative Care, and a professor of medicine at Harvard. From 1993 to 2015, for 22 years, James was on the faculty at Duke, where his last position was professor of medicine and chief of the Duke Palliative Care Program. He's the recipient of the 2002 Presidential Early Career Award for Scientists and Engineers, the 2006 Award for Research Excellence from the American Academy of Hospice and Palliative Medicine, and the 2013 George Engel Award from the American Academy on Communication in Healthcare. Dr. Tulsky's work has focused on two primary areas. First, doctor-patient communication, and second, quality of life in serious illness. He's widely published in both of these areas. His research includes the evaluation and enhancement of communication between oncologists and patients with advanced cancer, the identification of clinical, psychosocial, and spiritual trajectories of patients at the end of life, and the development of self-management interventions for patients with life-limiting illnesses. Dr. Tulsky is deeply committed as a teacher, mentor, and medical educator. His life's work is tied together caring for seriously ill people at the bedside, identifying what is most important to them, diagnosing in the process the shortcomings of our healthcare system that limit our ability to meet the needs of such patients. And his work has always tried to improve the lives of patients and their families and ease their suffering. Today, Dr. Tulsky will speak to us on the topic communications in serious illness, an evidence-based approach. Please join me in welcoming Dr. James Tulsky to the university.
So it is truly a pleasure to be here. It's for me this is a little loud. It's for me coming back home. I grew up in Chicago, so whenever I come back here, it is like home. And the University of Chicago has a special place in my heart. I've had a long-standing relationship here with lots of ways. My older brother and sister went to lab school. But also just with relationships with so many friends here, and known Dr. Siegler for many, many years, since he first tried to recruit me here to residency, and many years ago. And also I just want to say it's also an additional pleasure to be here at the behest of the Bucksbaum Institute, because to know that there's actually an organization out there that is focusing on the doctor-patient relationship and is really trying to build that up as the core of what it's doing is hugely important, and I think it's a fabulous thing that Chicago is doing. So here's my question. When you're talking to patients who are seriously ill about whatever, do you ever get stuck? And I'm seeing some nods. So I'm actually just going to really quickly ask. Just shout it out. Where do you get stuck? What happens? Where are the problems?
Giving bad news.
Giving bad news. Great. Thank you. Where else? What's hard? Oh, don't be shy.
Just knowing where to start.
Knowing where to start. Thank you. Anything else? Okay, I won't push you guys. But there are a lot of ways in which it's really hard when we're giving bad news when we're dealing with any kind of serious illness, it's usually about bad news. Knowing where to start, actually having a plan for how to get from here to there can all be very, very tough. And so what I want to try to do here is to give you a sense of, to appreciate the communication evidence base, to know a little bit about what patients want, to be able to talk a little bit about, what the impact is of communication on outcomes, to talk about the role of emotion and cognition in communication, which I think is really key and is about the giving bad news and it's about the where do we start, and talk a little bit about what real conversations actually look like. I want to talk about how training can actually make a difference. And where I want to end is to talk about some work we've been doing with new technology and skills dissemination and where we can go with some kind of cool things. So what I hope here is to, first of all, pique your curiosity and make you sort of want to learn a little bit more about some of these things. I want to begin to deconstruct communication and to say that it's not magic. It's not that somebody is simply good at it, or they have it, or they don't. There are actually, when you look at somebody who's really good as a communicator, there are specific things that they are doing that are different from people who have more trouble with communication. And as long as we know what those things are, we can learn and do more of them. And hopefully to inspire you to learn more. And a colleague of mine, Tony Bach, who I've done a lot of work with, wrote that the way you communicate is part of your work as a healer. You're not born with communication skills, you learn them. And so that's going to be one of the messages here. So let's just start with the premise of why do we even need to worry about communication quality in serious illness, and this may be self-evident, but I'm just going to sum up a little bit of literature. First of all, in general, good communication we know leads to greater adherence to therapy, probably because people have a better understanding of why they're doing it. It leads to higher patient satisfaction. It leads to fewer complaints and lawsuits. What we find is that it's not enough to simply be negligent or for there to be harm, which are the two things that have to be there for a lawsuit to go forward, but you also have to have poor communication. And good communication leads to elicitation of more patient concerns, and what we know is the more of those concerns you get out on the table, the more likely you are to be able to address them. In the field of serious illness, we know that end-of-life discussions, and when I say that, I mean broadly any conversations about goals of care or any of the issues approaching the end of life, are associated with acknowledgment of terminal illness by patients, preferences for comfort care over life extension, so we learn more about that when we've had those conversations. We know they're associated with receipt of less intensive life-prolonging care and more palliative end-of-life care, presumably in situations where that's what's wanted. And most importantly, care consistent with preferences. The gold standard in our field is what we like to call goal-concordant care. That is, patients get what patients want, whatever that might be. So here, this is a study from Alexi Wright from my institution, from Dana-Farber, before I got there. And it shows how this end-of-life communication drives care. And let me see, is this a pointer? Good. So this is whether or not an end-of-life discussion was documented somewhere in the medical record, either yes or no. And then what kind of care they received. Did they receive aggressive medical care in the last week of life? If there was a conversation, 37%. If there was not, many more. ICU admission was much more likely in those people who did not have an end-of-life discussion documented, ventilator use, resuscitation, chemotherapy, and hospice was actually longer in those people. Again, maybe self-evident, but it's good to document this. The other thing is that we know that prognostic awareness by patients affects their preferences. So if people know more about what is likely to happen to them, not surprisingly, they're going to have different preferences for the kind of care they want to have. So this was a study done by Jane Weeks a long time ago. And there you have the physician estimate of chances of 6-month survival. And then you have the patient estimates of chances of 6-month survival, either greater than or equal to 90% or less than 90%. And then the proportion of those patients who are favoring life-extending therapy. And over here, these are people who everyone thinks is going to live, very likely to live longer. So there the preferences are more toward life-extending therapy. But the interesting thing is if you drop down here and you look and you see where the physician thinks the likelihood of 6-month survival is very, very low. If the patient thinks that the survival is greater than 90%, and there are many people in that category who still think that, even though the doctor doesn't think it's anywhere near there. Of those people, 23 out of 38 would have preferred life-extending therapies. So the ones who think that survival is less than 90%, far fewer of them prefer therapies. And you can see what the odds ratios are as you get more discordant over here. So the bottom line is, if you believe that your life expectancy is shorter, you're going to change what your preferences are. Not surprising, but it's nice to document. And then finally, it's the right thing to do. Informed consent and shared decision-making require good communication. Good communication aligns clinicians and patients, and there's data to support that. And patients also say that they want it. In many surveys, people say they do want to hear about these things from their doctors. So given that patients say they want it, what is it the patients and families actually want? Well, this is what they want. Okay, they want this physician who they feel is somebody they can trust, who's, there's wonderful things I love about this Norman Rockwell painting. Among them are, the physician is sitting down on the bed at the same level of this child. This is actually before Epic. They're both looking at the chart together, the data is being shared. There's touch. Right, and actually the touch is going this direction, which is really kind of interesting. The patient leaning on the doctor. Obviously, it's a kid, but still, and there's a sense of concern, and there's a sense of togetherness that's really beautiful, and that's what people want. And so, how do we actually objectify that? How do we quantify that and turn that into something that we can actually talk about? So this is from a study that was done, a focus group of patients, and said, what is good communication toward the end of life? And they said it's when the doctor provides straightforward, understandable information, when the doctor elicits and responds to patient concerns, when the doctor is receptive to when patients are ready to talk. So this is a biggie, right? So that people want to talk about this, but they don't want to talk about when they don't want to talk about it. So you have to be somehow attentive to that. It balances honesty and empathy. And finally, it attends to emotion. This is what patients say that they want. And I've highlighted these last two because they're sort of both the conundrum and they're also the opening, they're also the key. Because the conundrum is, how do you do honesty and empathy at the same time? And I'm going to talk a lot about that. And then the other is, the way through this, in my mind, is much by attending to the person's emotion, which is often what's actually there that's getting in the way. So we know that families want honesty. This is from a study from San Francisco. Bernie Lowe and colleagues, 179 surrogates for critically ill patients in 4 ICUs. They were interviewed on day 5 of mechanical ventilation of their loved ones. And what they asked them about what do they want to hear from the doctors, and what these patients, 93% of these surrogates said that avoiding discussions about prognosis is an unacceptable way to maintain hope. Which is really interesting because a lot of doctors will say they don't want to talk about it because they're afraid of taking away people's hope. But in fact, that's not what people want. And common sentiments that were articulated in that study were that physicians have an obligation to discuss prognosis, that there was a moral aversion to false hope, and that people felt that prognostication was helping families prepare for the possibility of death. And they also want empathy. So this is from an interesting study, and I'll show you 2 studies that are sort of similar in this way. These were volunteers who watched a video of an oncology consultation. Now, this was a role-played oncology consultation. And the people who watched, 123 of them were breast cancer survivors, 87 of them were healthy women volunteers. It was a randomized controlled trial, and the videos differed, the 2 conditions of this study, only on the degree of what they called compassion, I would use the word empathy, that was entered into the conversation. So the enhanced compassion video had 40 seconds extra time in it, and those 40 seconds extra were with the doctor saying these 2 statements at 2 different points in the conversation. The first one is, I know this is a tough experience to go through. I want you to know I'm here with you. Some of the things I say to you today may be difficult to understand, so I want you to feel comfortable in stopping me. If something I say is confusing or doesn't make sense, we're here together and we will go through this together. And I know this is a tough time for you. I want to emphasize again, we're in this together. I'll be in there each step along the way. So there's a lot of alignment there. There's empathy. There's recognition of this being a tough situation. I could deconstruct what's going on here, but I think you get the idea. So the people who viewed the enhanced compassion video had significantly decreased anxiety watching it. By the way, they were just watching a video, but their own anxiety measured was significantly decreased. And the really interesting piece here is that it led to a higher rating of the physician on the non-emotional topics, not just the emotional topics. So they didn't just rate the doctor as being more caring, they rated the doctor as being someone who explained things better when the emotional piece was actually addressed. More examples of all this. Reduced anxiety and better psychological adjustment, and these are from a variety of studies, is associated with a doctor who is warmer and speaks more about psychosocial issues, from one study. And another study with nurses, so it doesn't just pertain to doctors if there are nurses or other healthcare providers in the room. In audio recorded conversations between cancer patients and nurses, the more nurses responded to emotion, the more patients actually recalled. And the distancing responses, which is when you sort of push away the emotion and kind of avoid it, were associated with lower recall. So if you want your patient to remember more, you actually address the emotional side of what's going on, and their recall is better. So the point here is this is not fluff. This is not about being nice. This is actually about helping your patient understand what they need to understand so they can take care of themselves and make good decisions. So how does this actually work? What's the pathway through which this sort of thing happens? Well, here's the issue. Emotion floods cognition. We all know this, right? We all know this. But there have been really nice functional MRI studies that have demonstrated this, which is that basically when you get excited about something, the cognitive areas of your brain shut down and the emotional areas of your brain, your amygdala and other places, fire up, and you don't register this other information. And this is a wonderful little piece this is unpublished data from a study that Steph Lee and Tony Bach did, where they were audio recording conversations between oncologists and patients, and then they did some interviews with patients afterward, and they also assessed what their prognostic awareness was. So this was a 38-year-old woman with AML. And so she comes in to see her doctor, and her pre-visit estimate of cure, that she thought her likelihood of cure was 90 to 100%. This is what her doctor said to her during the encounter. This is recorded from a real conversation. So if you had 100 people, the survival curve drops down because people die of one thing or another, including relapse. That tends to level off at about 2.5 years after transplant and stays level after that. It's about 30% in your situation, okay? This is what he says to her. They then surveyed her afterwards and asked her what her estimate of cure was. I'm sorry, they asked the doctor what he thought his estimate of cure was. He said 30%. Like, duh, that's what he just told her, right? They asked her, she said 90 to 100%. Then they interviewed her, and this is what she said. After he said the 30%, he just kept dinging along in his facts, and I was stunned. Literally, my note-taking was completely done. All I did was write 30% the rest of the time all over my paper. And I mean, I just couldn't get past that point. I don't know how to describe it. Fascinating, right? It's fascinating on many levels. First of all, she was clearly emotionally overwhelmed by the 30%, which she writes all over her paper, and then she says her survival is 90%, right? So none of this actually got through because the emotional piece was so overwhelming to her. So this is like one of my favorite studies, and it came out, I think, in 2013. That's another one of these video studies, and I think begins to explain how we get past all of this. And I didn't reproduce, at some point I should reproduce this graph, but I'll try to walk you through it. So this is another one of these videotape watching studies where they created 4 different conditions of video. As opposed to the other one, which was just 2 videos, this was 4 videos, and so it was a 2x2 factorial design. They had 51 breast cancer survivors and 53 healthy women. And the 4 different videos were, they had 2 things they manipulated. One was that either they gave explicit information about prognosis or not. So the explicit was like a number, and the not was kind of fuzzy. And then they either gave reassurance or not. Now what they called reassurance, I would call empathy. It's the kind of language I talked about before. And then you had the 4 combinations. You either got the information and the reassurance, you got the information with no reassurance, you didn't get the information, but you got reassurance, and you got neither. And the key piece here is that in the group that got the reassurance plus the explicit information, uncertainty was the lowest, anxiety was the lowest, self-efficacy was the highest, and satisfaction was the highest. Even more so than, for example, getting just reassurance alone, which you would say, like, how would that possibly be? Probably because people actually want the information, right? So they want information, but they want it to be tempered by addressing the emotional piece. So this leads to sort of this idea of a model of empathic communication. And the way that I think about this is, there was a wonderful article by Tony Suckman in JAMA a number of years ago, in '97, where he described this model. So first of all, empathy, which is a word I've tossed around for a while, in my mind, empathy is whenever you can say, I could be you. So if you look at the patient and you think, I could be you, you can imagine that, then you're feeling empathy. By the way, identification is I am you, which is pretty unhealthy, but happens. And sympathy is I feel bad for you. Okay, so empathy, though, is, I could be you. And empathy, by the way, by itself, to feel that is important, but the real key question is, do you communicate it to the person or not? Do they know you're feeling it? Because if they don't know you're feeling it, then it doesn't really make a difference that you're feeling it, therapeutically at least. So here's the thing, this is the theory. So there are these moments called empathic opportunities, when patients explicitly or implicitly express emotion. And then what happens is you've got a branch point. You can either respond with this thing called an empathic continuer, or you can respond with a terminator. And if you respond with a continuer, this is what I'm sort of suggesting is this reassurance or whatever that kind of helps people along. The terminators are what distancing and create all the problems I mentioned. This is an example of a continuer from a real patient conversation. The physician says, how do you feel about the cancer, about the possibility of it coming back? The patient says, well, it bothers me sometimes, but I don't dwell on it. But I'm not as cheerful about it as I was when I first had it. I just had very good feelings that everything was going to be all right, but now I dread another operation. That's the empathic opportunity when the patient talks about their fear. Physician says, you seem a little upset. You seem a little teary-eyed talking about it. I would call this an empathic response. Actually, if you want to be specific, it's a naming response. And this would have moved the conversation forward and been therapeutic. An example of an empathic terminator. Physician says, does anybody in your family have breast cancer? Patient says no. Doctor says no. Well, after I had my hysterectomy, I was taking estrogen, right? Yeah. You know how your breasts get real hard and everything? You know how you get sort of scared? Again, an empathic opportunity. How long were you on the estrogen? Well, maybe about 6 months. Well, when did you have the hysterectomy? Moves forward, okay? Now, something I want to be clear about. It is possible that you can't respond to every empathic opportunity. And if a lot of them come up, you may sometimes decide you simply have to blow past it because you have too many patients to see that day. The important thing in my mind, well, I have two things to say about this. One, I'm going to show you in a moment there aren't nearly as many empathic opportunities as you think. And the second thing is that it's okay, I think, if you blow past it, if you know you're doing it. I worry about it when people, if you're making a choice and you say, I just can't do this right now at this moment, that's one thing. But if you don't even notice it and wouldn't imagine how you would respond, that's another. So given all of this background, and given the importance of communication in serious illness and how I believe it plays into what happens, what actually happens in clinical practice? The good news is we have some windows on this. So first of all, this is actually from a study that was done by Elizabeth Lamont, who, when she was here at the University of Chicago many moons ago, and together with Nicholas Christakis, and they looked at 326 cancer patients who were referred to hospice. And these were patients in this community. And the referring physicians were asked, what was your formulated survival? What did you think the survival was? And what was the communicated survival? What did they actually tell the patient? And what physicians communicated was, it was no survival estimate at all at 23%, the same estimate they formulated in 37%, or a discrepant estimate in 40% of the cases. 70% of those times they were more optimistic. These are patients that are actually referring already into hospice. You would think the hard work was already done, right? And yet they're still having trouble with over-optimism. Okay, what about audio recorded visits? Well, what we know is that physicians miss a lot of empathic opportunities, and I'll show you a few studies. So this is from a study of 10 oncologists and 240 incurable Dutch cancer patients. 64% of the time was spent by the physicians on medical or technical issues. The patients spent 41% of their time. 23% of the doctor's time was spent on psychosocial issues. The patients spent almost 50% of their time on it. The mismatch in terms of what patients and physicians do. This is from a study of 297 Australian cancer patients and 9 oncologists. 72% of them responded to informational cues. And an informational cue is like a question about a drug side effect, okay? But only 28% of them responded to emotional cues. Those emotional cues are the same thing that I would call an empathic opportunity. So when those empathic opportunities arise, only 28% of the time did those oncologists actually respond to them. I want you to remember that number, because we're going to come back to it. And this is a study from Seattle of 51 ICU family conferences. This was in the ICU there. And what they found was that clinicians who were running these family meetings in the ICU spoke 71% of the time during the meeting. However, when they measured satisfaction and so forth, what they found was that the more the family talked, that was what correlated with satisfaction with the physician communication. So the families who talked more thought the doctors were better communicators, and the families who talked more also perceived less conflict with the doctor. So all of these kind of hint at, you know, this kind of at a kind of communication we would like to see, and not enough of it. And from here, over the next few slides, I'm going to talk about some of our own work. And this is from a study we called SCOPE. And we've done this in several phases. But in the first phase of this, we enrolled 51 oncologists. These were medical, surgical, and radiation oncologists, and 270 patients with advanced cancer. This was at Duke and also at University of Pittsburgh Medical Center with my collaborator, Bob Arnold. And we audio recorded 398 outpatient visits. Some of these patients had 2 visits, which is why there were more than the number of patients. And then we coded the encounters. And we have 2 independent coders. They're trained extensively. 15% of these we double code. Our inter-rater reliabilities have been greater than 0.7 on a kappa. I'm happy to talk through sort of the methodology of that if people have questions about any of those issues. And just to, some people are curious about sort of how we do this work. This is a program we developed to do it called Encounter. I'll show you a more recent version we've just created called Ava in a future slide. But the way this works is we audio record these conversations, and then you have playback over here. This is just sort of the audio file. The cursor moves along. You can see that there's a demarcation here between this green and this red. This is a segment. You stop on a segment. We have a code book with all these different codes of what different types of talk could look like. You pick a code, you know, for example, empathic response or something, and then when you pick up the code, you have variables that can, like, you know, yes, no, whatever it is. Direct, indirect. You click on the drop-down box, and then once you sort of save it, it goes in over here. So if you were to click on any of these, like you click here on the green, you would actually go straight back to the playback of that particular code. But more importantly, living behind this thing is a SQL database that turns all of this into data that can be manipulated like any other sort of data. So sometimes people talk about this as being qualitative research. It's actually not. It's actually quantitative research. It's just taking qualitative data and turning it into quantitative numbers. The analogy would be the same way you have sort of a scale that measures something like depression, takes this kind of qualitative thing called depression, and through a number of different questions turns it into a number that we then can score. So what we found in these studies of these almost 400 conversations, there was a grand total of 292 empathic opportunities. So this is what I was referring to before when I said there may not be as many as you think. And 47% of the patients expressed one at some point in their conversations, and 62% of these conversations had no empathic opportunities at all. To be perfectly honest, this surprised us. It surprised us because every one of these people had advanced cancer. They were going in to see their oncologist, and even if they were going in for relatively routine visits in some cases, kind of hard to imagine that none of this stuff came up, but not a lot of it was there. And we have a hypothesis for why. These are the responses to the empathic opportunities. So 27% of the time they were met with continuers. 73% of the time they were met with terminators. And the really interesting thing here is, if you remember back to that Australian study, the number was 28%, and we got 27%. So it's, halfway across the world, we're coming out with the same thing in 2 English-speaking countries, which is kind of remarkable. And 52% of the physicians had 0 to 1 empathic statements at all over a total of 8 visits. 41% of these oncologists had none. Now, before I start getting tomatoes thrown at me by the oncologists in the room or any other doctors, these are really good doctors. And I know a lot of them. And they're good doctors, and if you listen to the recordings, they sound kind. And they're good, and they're trying hard, and they're good people. What they're not doing is they're not explicitly responding to the emotional content that's coming to them. And this is, as I'll talk about in a moment, really a skills issue. So it turns out that the type of statement makes a difference, the type of statement made by the patient. So this is from a sub-study of it's a sort of a second study from the same group. 264 conversations between 264 patients and 48 oncologists. Here we went 1 for 1. What we found was that fear was the most commonly expressed emotion when people did bring up an emotion. And that's maybe not a surprise in a cancer clinic. 67% of the time when there was an emotional statement, it was fear. Sadness and anger were the least expressed. Oncologists were more likely to respond to, actually that should say, oncologists were more likely to respond to anger, and they were more likely to respond to the actually that should say oncologists were more likely to respond to sadness. They didn't like responding to anger. And they were more likely to respond to the more severe emotions. We measured the emotions, we gave them a scale of sort of mild, moderate, and severe. So not surprisingly, the more you ramp it up, the more likely your doctor is going to be to respond. So there's a certain point at which you kind of have to do something about it. But the interesting thing was the fear, which is there all the time, that's the thing that was being most ignored. And that's kind of the elephant in the room. And the other thing is that when they did make empathic responses, it resulted in more discussion 82% of the time. So if you said something empathic, the patient would usually continue. However, contrary to people's worries, which is that you're going to open up a can of worms and you can never close, the discussions only lasted 21 seconds more when an empathic statement was made. So the bottom line here is you can say something empathic, you can respond to the emotion in the room, and you will still get out the door and be able to see your next patient. So I've presented a lot of data to suggest that this is important, what the causality is and how this may play out, and the fact that we don't do nearly as well as we'd like to do. So the question comes up, can we do better than we're doing? And here's where see one, do one doesn't work, unfortunately, for a whole bunch of reasons. We don't believe, because the truth is, that's how everybody's learned. Everybody has learned by seeing what's around them, right? By being role modeled. So the problems are, first of all, many of the role models are simply poor communicators themselves. So if you're watching people do it, they don't do it well, you don't learn to do it well. The second thing is it's easy to watch and think you can do it. Turns out to be an extraordinarily different thing to actually say the words. And I'd be happy to talk about this with questions, but we've done a lot of work where people get taught exactly what to do, but until they practice and actually say it, they know what they want to be saying, but to actually have it come out is a different thing. So how do we know if we're doing well? This is one of my favorite studies. This is was a study of house staff, medical house staff at the University of Washington. And what they did was they asked their doctors, the house staff, to rate themselves on their communication skills, what they thought, how good they thought they were on this scale, right? And then they asked patients to rate how good they thought their doctor was. And they matched them. Each of these points is a match between a doctor and a patient, okay? And as you can see, it is an entire scatter plot. There is absolutely no correlation whatsoever between how well people think they do and what their patients think about them, except for this person over here who knows that he or she is great, and the patient loved him or her, and this poor schnook out here who knows that he's terrible, and the patients think he's terrible. Okay, So it turns out that communication is a learned expertise, as are most skills, right? You first learn to ride a bike, and you've got training wheels. And you kind of try to stay stable, and you're just happy to kind of get down the street, right? And then it starts getting fun. Because you can get the training wheels off, you have a little bit more freedom, you can play around with it, and you start getting better. And over here I would call this novice, and here I would call that skilled, right? And then at some point you hit mastery, where you really can do better than everybody else. But to get from here to here takes what is it, the 10,000 hours of practice to learn a new skill. It takes a lot of practice and observation. So we know, how can we teach people? Well, we know that one model that definitely works for teaching communication skills is small group learning using simulated patients, actors, and so forth. And there have been a number of studies that have done this. The best that was done by Leslie Fallowfield in the UK. They did a randomized controlled trial of 160 oncologists. They did a 4-arm study where people either got a communication skills course, which was small group teaching. The second option was they got written feedback, where people observed their communication, videotaped their communication, and then gave them written feedback about it. The third arm was that they got both the written feedback and the small group teaching, and then the fourth arm was they got neither. And what they found was that the groups that had a course had demonstrated more empathic statements, fewer leading questions, more open-ended questions. They were looking at a variety of other things as well. Interestingly, written feedback made no difference. So the only thing that actually made the difference was the course and the practice and the training. So in our work, we've done, together with my colleagues Tony Bach and Bob Arnold, who've already mentioned, we've done a lot of work in developing this kind of model here. We created a program called OncoTalk, and then after that, a program called OncoTalk Teach. These were NCI-funded programs in which we trained oncology fellows. And actually, over the course of a period of 5 years, we trained almost 20% of the fellows in the country using this model. And what we learned was that it works. So again, and we have more data than this, but this is just one to show you. These are a whole series of skills in delivering bad news. This is how people did beforehand. We pre and post tested them with simulated patients. This is how they did afterwards. Most of these are significant in terms of the differences. Over here, what you're seeing is how much people learned of the skills. If they didn't already have the skill, how many new people acquired them, and the majority of them acquired them. So we found that this was a 2.5-day course, we found that we could definitely get this done. And there are a lot of impacts about this kind of teaching beyond the numbers. Faye and I were talking before, and I think we have a similar experience, but one of our fellows, after she took the course, went home, and her first patient said to her, "No doctor has ever talked to me like this." So she started using the skills she had learned in the course, and she sent me an email and was like, oh my God. My favorite, though, was from a oncology fellow at Duke. We started doing this course at Duke, and this was actually my last year there, I think 2012, maybe the year before, 2011. And I get this email from him a week after the course. And he says, "When I saw a patient today that was distressed, I was able to name the emotion, use empathic statements, and use praise statements." These are all things that we teach. "I never once used the word chemotherapy, death, dying, prognosis, or treatment. The patient was able to get out what they needed, and the conversation segued smoothly into moving forward from here and what we need to do to get there. As a matter of fact, he thought I was the best physician he'd ever seen. And I didn't even talk to him about his cancer. I couldn't believe it. It was freaking amazing." It was like a switch went off in my head, an epiphany, that if I just talk to patients in a way that provides alignment, I will be able to ultimately provide better care. Needless to say, that made my week, my month. But that's what we're going for. And it is that, it also is not only obviously great for the patient, but it's enriching, obviously, for this physician who I think is now going to have a different experience as an oncologist. So all this leads to another question, which is, can we train more efficiently? One of the problems is that these small group courses work, but they're time, labor, and cost intensive. And the models have been, the ones that have been best tested and proven are anywhere between 2.5 and 4 days, although we believe that the one-day courses probably work as well. And hiring simulated patients is expensive. There's a lot of things about it that are hard. And also to pull people out of practice is hard. So we need effective, inexpensive, easily disseminable educational alternatives. And so what did we so we've stepped back and we said, okay, what's actually happening in this training? And every training for communication skills includes three things. Observation. Learners need to see what good looks like. Second, they need practice. It's not enough to know what to say. The words have to be practiced, ideally in low-stakes situations. You know, just like you wouldn't learn to ski going down the double diamond, right? You learn to ski on a green slope. And goal-directed feedback. Did you do the task, and what was its impact? Can you get some kind of feedback on what you did? So we did a trial. This was a follow-up to the one I described before called the SCOPE trial. And what we did here was we randomized these oncologists to two groups. We recorded their visits. They either got an online program or just a 1-hour lecture like this, which turns out to be useless. And then they, at least in changing skills, and then we recorded their visits again afterward, and then we measured patient satisfaction. And this was a little old. We used CD-ROM technology. We've moved all of this online now. And it included information, included video clip demonstrations, and this was the key, audio clips from the oncologist's own recorded conversations, because we wanted them to have feedback on what they had done themselves and not be able to say, I don't do that. And then we had a number of motivational techniques built in to get them to commit to try new behaviors and receive email reminders prior to their next clinic. And this is what it looked like. It wasn't very pretty. I'll show you our later model, which is a lot prettier. But what we did was, we said, in your recorded encounters, there was one example of an empathic opportunity. Click the button here to hear it. And then you'd play that. You'd hear your voice. You'd hear the patient doing the empathic opportunity. You'd hear your response. And then a little voiceover would come out and say, that was great. Do more of that. Or next time, you might want to try doing it like this. And then we had them commit to action steps. Next time you're in clinic, are you going to do these things or not? And what we found was they used it. They spent a median of 64 minutes with the CD, which is exactly what we wanted. So we've turned a 2 to 3 day course into a 1-hour CD. 92% reported changing their clinical practice since viewing the CD, which is all well and good, but more importantly was the data. And what we found was, cutting to the chase, there were twice as number total empathic statements made by the doctors who used this CD, and when confronted with an empathic opportunity, they were twice as likely to respond with an empathic response, with just a 1-hour CD. And the other thing was that, and these are some other things, and on the trust scale, we measured patient trust, and the patients whose doctors used the CD were significantly more likely to rate them higher in trust than the ones who didn't. So we were thrilled. This was great. We published this. I got about a bunch of inquiries about it, but it wasn't ready for prime time. And the question came up, can we disseminate this into practice, and how do we do that? So we realized dissemination requires a few things. It requires a platform, it requires carrots, and it requires sticks. And so we thought, who are the best at carrots and sticks? The American Board of Internal Medicine. And so we went to the ABIM, which has something called the Maintenance of Certification Program. So some of you know all about this. Some of you know too much about this. I was smiling there because this program imploded recently. But anyway, MOC is a program by which all doctors, but we were focusing on oncologists, have to recertify in their specialty every X number of years, usually every 10 years. And that requires them to do a bunch of things, including like self-administered tests and things like that. And there used to be something called a PIM, a practice improvement module, which was some way of sort of doing something in your own practice. So we thought, wow, maybe we can make one of these PIMs be a communication PIM. They actually already had a communication PIM, it just wasn't very robust. And they were looking to do this. So we, so what we did was we teamed up with them. We said, if you guys be willing to do a trial with us where we make a PIM that does this program we just did, and we can incentivize the docs to do this. They all have to do MOC anyway, so we gave them 40 MOC points to do this as opposed to the usual 20. We gave them 30 or 40 CME credits, and we gave them $75 off their maintenance certification fee. And so we did all these things to try to incentivize them. Now, the problem was that in the middle of all this, the program imploded, and they removed all PIMs. But the ABIM has played along with us very nicely, and they've kept this PIM as an experiment. So this is the study design, and basically we enroll people, we randomize them, they either get the standard PIM, which is they just are basically encouraged to figure out their own action plan to learn communication, or they get our online skills training. We then collect baseline data. What they do is they do a survey. They survey their own patients in their clinics, in their practices, 25 patients. Then they record 4 visits. Then what happens is both groups receive the patient survey results about patient satisfaction with their provider. The doctors in the control arm just develop an action plan based off the feedback, whatever they want to do, really. The scope doctors go through our training program, and then we collect the data again, and we're going to see what the outcome is. We also added one more thing. We got this funded by PCORI, the Patient-Centered Outcome Research Institute, for a 4-year study. And PCORI really cares about patient involvement, so we added a piece to this. So instead of just doing what we did before, which is capture the doctor's the audio encounter and do the coding and give them feedback, we added something called patient review. We've enrolled now 15 cancer patients from around the country who we've trained to listen to these conversations and to give their own feedback as well. So now the doctor not only gets the coded feedback from us that tells them about empathic opportunities, but they also get a voiceover from a real live cancer patient who says, "Doctor, I really like the way you did that." Or, "Doctor, next time you might want to try doing it like this." And that's actually, it's even more personalized. It's not their patient, but it's somebody else. And we've developed, we've now turned this, I was talking with the medical students before about sort of how do we disseminate these things. So we've created an app. It's the AVA app. It's right there. You open it up. All you do is click that button, add recording. You get the screen. Bingo. There you are recording your visit in clinic. In fact, it even works if you keep your phone in your pocket, and you can still hear the conversation. And it's good enough for us to be able to record, to analyze. This is the new form of that encounter program I showed you before. This is called AVA. And here what you can see is, same idea, segments and all that stuff. But this is where the patient can listen as well. And here the patient wrote in here, "I like that you listened to the patient's concerns and answered their questions while staying with your professional recommendation." And then what they can do is click play, and they can actually record their voice and put that in there. This is what the online program looks like now. We've obviously done a lot better with graphics since the last time. And when you go through your study status, now it's time to collect patient surveys. Then you have to record the encounters. So you walk everybody. They keep coming back to this website. It's all routed through the ABIM. The ABIM recruits the patients. I'd be happy to give you more details. This is the whole training contents. And they walk through all these pieces, and they learn these different skills, ask, tell, ask. And we also teach them a goals of care tool called Remap. And so then here, for example, is a section on giving information, ask, tell, ask. We tell them what to do. And then over here, they get to actually play an example of what it sounds like so they can hear it. In fact, they can then watch an example, and they can see a video of it as well. And here, I'll just show you really quickly what some of these look like.
So the usual course of treatment is 6 cycles of chemotherapy over the next 4 months.
Oh, man. I thought I was done. Do I really need more chemo?
I wish there was an easier way to treat the cancer.
Me too. It's just so overwhelming. But I know I'll get through it.
The point here was we taught this skill called a wish statement. I'm not talking about all these right now, but that patient says, do we really have to do this? And the typical oncologist response would have been, well, the data shows that you really have to do this, and those are the best responses, and blah, 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 right? And instead she just says, I wish there was a better way to do this. And he's going, I wish so too. And then he kind of relaxes, and he's going to be accepting of this because that response was an emotional response to what was going on. It wasn't necessarily a factual question. And here, I think I just clicked to another one. This is, let me see which one.
I am in this.
So this one is where, well, let me see, is this, we'll just play it through.
For the long haul. I want to keep fighting. But I also want to spend as much time as possible with my family. Is it possible for me to go on a vacation with them?
Okay, I hear you. Fighting this cancer is important to you, and you want to find a way to get a vacation with your family, right?
So sorry, I forgot exactly what was going on there. So I don't know if you noticed the pause there, right in the middle. That pause was deliberate. So what happens is that the pause happens when you watch it on the screen, and then you get to type in what your response would be, or say it. And then you get to watch what the actual response should be. And that was an example of an aligned statement. And there's one more example, but I see we're hitting toward the end of the hour, so I'm just going to skip through that one. And then what happens is you get to the point where you get to see your examples of your own audio recordings, right? The other one was the screen where you get to hear the patient responses to you. So it all plays out like that. So in summary, good communication enhances patient outcomes and experience. We also know that clinicians have to attend to emotion for serious news to be heard. Communication skills can be taught, and new technologies provide some interesting opportunities for widespread skills training and quality control. And the last thing I want to do is just share a couple of resources. I work with an organization called Vital Talk. So when I talked about all the stuff we've been doing with OncoTalk, what we ended up doing after being supported by the NCI for many years is realize we needed to do this in a different way. This is a nonprofit, don't get a penny from this. But we have a website, you can go to vitaltalk.org, where you can learn a lot about communication skills, and there's a lot of opportunities on there, and as well as examples and videos and things like that. We now have two apps, the Vital Talk app and the Vital Tips app. You can get both of these at your App Store. This one I think costs $2.99, this one's free. We have an online serious illness communication module, which costs a little bit of money, it's not too bad, which is a course that you basically sign on to and takes several hours and has lots of examples of videos and has you sort of critique communication that you see and try to identify what you're seeing and then learn various skills. And then finally, shameless self-promotion, we also have a book. So I'll stop there, and I don't know if there's any time, but happy to answer questions. Thank you.
Are there any questions? Dr. Tulsky? I have one. Seems to me more difficult than communicating is listening. That is, how do you teach that skill? Because you have to be listening very hard to pick up the cues.
Yeah, that's great. So I think the question was, listening is as important as speaking, and how do you teach that skill? I think the main way we teach it is by teaching people to be really good observers. So for example, that online program has people describe exactly what they're seeing the doctors do in the encounters. When we teach a Vital Talk course, Manny knows this, we hand everybody we give them all a beautiful little moleskin notebook at the beginning of the course, and throughout the entire course we have them write down everything. Whenever there's a doctor-patient communication going on, we have them write down, we actually teach them how to keep track of it. When you start paying attention to the words that both the patient's saying and the doctor's saying, it gets you into the mode of being able to listen better, and then you start appreciating what you're hearing. The other thing is that some of the skills, like that last thing that doctor did, where he repeated back all the things the patient had just said, we call that aligning. You can only do that if you've actually heard it really well, so we teach that as a skill too.
So, what you've just gone through is certainly useful if the patient is fully competent. A lot of patients, especially ones with mild but not terribly advanced dementia, may still have a fair amount of intellect left, but they don't probe and they don't question and they don't synthesize verbally, and their opinions and desires can be determined very often, but only with very slow, careful questioning where you make your questions in a way where you don't expect much more than a yes/no answer. You got tricks for that?
So I think you're pointing out something really, really hard, which is the reticent patient, the non-verbal, less verbal patient, the somewhat cognitively impaired patient. I guess what I would say is that empathic communication always works. Those emotions are there, it's probably the last thing that's going to go, right? So you can always respond to the emotion and do that. And, as far as, getting defined decisions and things like that, that may be tougher. And I think if somebody is really at the point where they're that concrete or having that much trouble, I think we're entering into sort of a special realm of, of sort of tougher communication, or where they may not even be entirely have certain kinds of decision-making capacity. I think the thing I would fall back on, though, is that the emotional response skills still work, even in those patients. Marshall?
So a related question then. Is it known how this approach translates across cultures, or what type of cultural healing is necessary?
There's not a lot of great data across cultures. There's some. So I would say that in Western, particularly English-speaking cultures, this is pretty much the same across the board. We've audio recorded, Duke has a medical school in Singapore, Duke NUS, and we've done some work over there, and we've recorded a bunch of conversations between oncologists and patients there. And some of them are in English, some of them are in Chinese. And the conversations are very, very different. And the other thing is the families don't like empathic communication. They actually specifically say they don't like that. So we're trying to figure that one out right now. So it's clearly different in that context. And I don't have any data except to say that yes, it is different.
So I thought it was interesting, one of the pieces of data you presented said about 60% or so of conversations did not contain empathic opportunities. So I'm wondering, in that subset of conversations, is there room for physicians to create empathic opportunities with patients, and have any studies been done on that, and how it improves outcomes?
Yeah, so I think that, and by the way, the first thing I think is that the reason that there's so few is because we train people out of it. So I think that, the message is, this is not the place for you to express your emotional concerns, because you're going to get a negative response, and so therefore people stop doing it. So the first thing is, the more we do it, I think the more we're going to invite. And then the second thing I'd say is that there are many opportunities to make empathic statements, even when there is no when there's no empathic opportunity, and you can just sort of comment on the situation. You can praise a patient. There's a lot of things you can do, and that will oftentimes open up opportunities. There's not a lot of data on that. I can simply say from personal experience and sort of using this a lot with my patients, that even when patients don't bring things up, if I sort of try to go there, or getting back to what Dr. Siegler was saying, the more you listen or the more you invite it, and also asking more open-ended probing questions that, what is your understanding of your illness? What are your concerns? Are ways to get at that.
Thank you. Very great talk. And I like your platforms that you're using. Is the one, the AVA and the scope, is that available on VitalTalk in terms of taping and then listening?
So they're sort of done separately. AVA as an analytic program is available, and I could tell you who you can purchase that from, and you could use it for your own coding work or anything like that. So you can buy that, if you will, as a platform to work off of. And that's generally the coding app. They probably could also provide the phone app. But that's separate. It's a company called People Designs in North Carolina that's actually developed that. But if you're interested, just send me an email and I can send you to the person who could help you with that.
Did you have issues about taking patients in your clinical environment and getting, HIPAA?
Oh yeah. Oh no, we had no issues whatsoever. It took me a year to get this study through the Dana-Farber IRB, but we did. These are patients all over the country, in practices all over the country. These docs are just enrolling them. The patients do online informed consent. The only thing that is identifiable, PHI, patient health information that's identifiable, is their voice. So it's called biometric data. So the fact that you actually have a voice print that theoretically can translate to somebody. As soon as we get these recordings, we immediately mute out all the doctor names, patient names, location names. However, we do have that data before it hits us. It's all on secure servers. And then after that, none of that's there. But the voice, the biometric is. We've got patients, we got them to agree to this, to a consent for that. And we have 1 million IT protections on this stuff.
Thank you.
Sure.
James, thank you so much.
You're welcome.